Okay, a female has a mild a female a female newborn has mild cyanosis and a cardiac murmur 4 hours after an uncomplicated vaginal delivery. 4 hours after an uncomplicated vaginal delivery. Heart sounds are heard of the right. A chest X-ray showed dextrocardia. No evidence of pulmonary disease. Echocardiography shows a complex congenital heart defect with a regurgitant AV valve. Abdominal ultrasonography shows no evidence of spleen. A blood smear show whole jolly bodies. The newborn is greatest risk of what? Okay.
One moment. Mm, my mind went blank. Natural body
If there
cells.
is no spleen, then what will happen?
Ah,
Okay.
okay. Mm, Sepsis as a consequence of asplenia. Sepsis as a consequence of asplenia is the most likely potential complication in this patient. Asplenia can occur as a result of congenital anomalies, as in this case, trauma or chronic thrombosis in conditions such as sickle cell disease. The spleen plays an important role in clearance of bacteria, especially encapsulated pathogens such as Haemophilus influenza, Neisseria, strep pneumonia, Pseudomonas and Klebsiella. It also removes cells infected with intracellular parasites such as Babesia. Thus, patients lacking a spleen are at risk for infection with parasites and encapsulated bacteria. And the spleen functions to remove opsonized bacteria and cells infected with bacterial parasites, both by mechanical filtration in the sinusoid and through phagocytosis by splenic macrophages. Additionally, the spleen is a large lymphatic organ that houses many immunoglobulin producing B lymphocytes. Any fever or signs of infection in a patient with asplenia should be treated immediately with antibiotics. Anemia is not caused by asplenia. Erythrocyte progenitor cells exist in the bone marrow, therefore, erythrocyte production is not impaired in splenic patients. However, the spleen does play a role in removing senescent erythrocyte from circulation. The presence of Howard body, which represent erythrocytes with nuclear remnants, is typical of asplenia. These abnormal erythrocytes are removed by the spleen. Okay, next.
Okay. 4 day 4 days after admission of 4 days of after admission to the hospital for evaluation of high grade fever, a 12-year-old girl has decreased urine output. Her urine output has been 2 ml per hour during the past 12 hours. She has 4 week history of temperature. She has 4 week history of temperature to 40, to 40 degree Fahrenheit, 40 degrees Celsius, 105 Fahrenheit, facial rash and diffuse joint pain. On admission, her on admission, diagnosis of hypertensive encephalopathy was made and antihypertensive therapy was begun. Her current temperature is 103, pulse 110, respiration 45 per minute, blood pressure 168 by 90. The remainder of the examination shows no abnormality. Sodium is low, 129, potassium is 9, BUN blood urea nitrogen is 130, creatinine is 10.2, urine is RBC is more than 100, RBC cast is occasional an ECG is done. Which of the following is the best next step in the management? What have you found in the ECG?
Oh shoot, I didn't even look at it. Uh,
There is tall peak T wave.
Let me see. Big T wave, so I mean, okay, we already know there is hyperkalemia. So calcium was then okay, so we give calcium chloride, or do we do hemodialysis because the the kidney is gone? Mm, no, no, okay, let's give calcium chloride. Okay, feel like it's hemodialysis. Ready?
Yes.
Okay. Oh, calcium chloride. Um, Systemic SLE is an autoimmune disorder with a wide range of presentation. Cutaneous manifestation includes red rash over the mother cheek that spares the natural light before, after sun exposure or display lesion with hyperpigmented edges, and pink atrophic centers. Pain is oral ulcers and non-specific hair loss may occur. Fatigue, joint pain, and fever are also common presenting signs. Lupus nephritis is a common complication of SLE and is common in younger women. It can present with hypertension, hematuria, and increased creatinine in the setting of SLE. Lab evaluation generally shows a low complement concentration. Lupus nephritis leads to AKI with increased creatinine, which can present with oliguria and anuria. Patients may be asymptomatic or demonstrate symptoms of uremia, fatigue, nausea, vomiting, pruritus, and metastasis, hyperkalemia, peak weights on ECG, and hypovolemia. If the AKI is severe, severe hyperkalemia leads to decreased myocardial excitability, resulting in repolarization abnormalities, conduction dysfunction, heart block, bradycardia. These abnormalities can manifest on ECG with peak T-wave, PR interval prolongation, loss of P-waves, and if severe, widening QRS complex and bradycardia. Hyperkalemia resulting in ECG changes require the emergent administration of calcium gluconate, calcium chloride to induce cardiac cell membrane stabilization. Further treatment after calcium may involve insulin and glucose biagonists, beta agonists, bicarb to shift potassium into the cell, loop diuretics to facilitate the urinary excretion of potassium, and sodium polystyrene sulfonate to promote binding of potassium with the lumen of the gut. For severe or refractory cases, dialysis may be necessary. It's not E. Patients with severe hyperkalemia may require hemodialysis. However, the first step requires the administration of calcium chloride to emergently stabilize the myocardial membrane prior to attempting to lower potassium concentration with medications or dialysis if refractory. Okay.
If refractory, then hemodialysis, isn't it? First, we
Yes.
will go through, like in if we look at the management of acute hyperkalemia, then rapid within minutes we should give calcium gluconate or calcium chloride, which will antagonize the membrane action of potassium to decrease cardiotoxicity. Like in here, there may be a chance of having diastolic failure. That's why we stabilize the heart by giving calcium gluconate, and we can give beta agonist albuterol, which shifts the potassium into the skeletal muscle. We can use insulin plus glucose, which shifts potassium into the skeletal muscle, and we can add sodium bicarbonate. We can give loop diuretics, and we can give loop diuretics or thiazide diuretics can be given, and exchange resin like pactiromar or sodium polystyrene sulfonate. These two drugs actually eliminates potassium from the body, and the sodium bicarbonate shift potassium into the cell. Okay.
Okay. Next.
Okay. Oh, I need to read. Okay, sorry. I sometimes forgot. Okay, a 15-year-old girl is brought to the emergency department 2 hours after attempted suicide by taking an overdose of aspirin. She taking an overdose of aspirin. On arrival, she appears slightly agitated. Temperature is 100.4 degree Fahrenheit. Pulse is 112. Permanent respiration 34. Blood pressure 118 by 72. Examination shows sigh-like respiration and diffuse mild abdominal tenderness. This patient is most likely to have the following sets of electrolyte findings. Like salicylates or aspirin, isn't it? It has
Mm-hmm.
both metabolic acidosis and respiratory alkalosis.
Mm-hmm.
Early is respiratory alkalosis.
Mm-hmm. Mm-hmm. 130, 136, 141, 5.4. Mm. Ready?
Yes,
Let's see. Aspirin is an antiplatelet agent that irreversibly activates COX, that irreversibly inactivates COX, which prevents the conversion of arachidonic acid to thromboxane A. Thromboxane A is involved in platelet activation, and its decreased synthesis results in diminished platelet activation. Beyond its effect on platelets, salicylate poisoning in large doses results in respiratory alkalosis from stimulation of the respiratory centers, causing hyperventilation. Subsequently, it results in the development of the renal metabolic acidosis, secondary to its decoupling effects on the electron transport chain, resulting in increased anaerobic metabolism and the production of lactate and keto acids beyond the acidic properties of salicylate itself. It does not typically affect the sodium and potassium concentration. Patients with salicylate toxicity will present with hyperventilation, GI upset, hyperthermia, tinnitus, agitation, delirium, and hallucination. Management of salicylate involves systemic alkalinization with sodium bicarb infusion. Patients may need dialysis in the setting of severe acute mental status, end-stage renal disease, pulmonary edema, and clinical deterioration.
why it is not B?
B. Salicylate poisoning will be unlikely to cause hyponatremia or hyperkalemia, A or B. Hyperkalemia commonly occurs in renal insufficiency, aldosterone deficiency, and RTA. Salicylate toxicity results in anion gap metabolic acidosis secondary to the production of lactate and ketoacids and will not result in a normal or increased bicarb concentration. While patients may have respiratory alkalosis during the early stage of salicylate poisoning, it will not cause metabolic alkalosis and will not present with hypernatremia.
So main thing in here, like first we need to find out the salicylate poisoning is respiratory alkalosis. Then we need to find out that salicylate poisoning does not cause hyperkalemia. Then we can easily exclude out.
Mm,
How you pick this
I
answer?
just the only things I think this is we had a similar question before. The only things the salicylate affects is the bicarb and the CO2. Everything else should be normal.
Yes, oh, there is only bicarb is given, no CO2.
Yeah, so
Then
everything
how?
else. Then
13 and 8 is same.
but everything else should be normal.
Oh,
Chloride
okay,
one, chloride 112 is high. It cannot be B. 112 chloride
okay.
is high. And then 5 point. Wait, let me see. 5.4. Yeah, it's high too.
Potassium is high. Chloride
Yeah,
is high. Potassium is
so it cannot be this.
okay.
It-
A previously healthy 10-year-old boy is brought to the emergency department 1 hour after falling against crossbar of his bicycle in a straddle position. In a straddle position, he has not voided since that time. He appears to be in severe pain. His temperature is 37 degrees Celsius, pulse is 120 per minute, respiration 25 per minute, blood pressure 105 by 75. Examination shows large perineal hematoma, large perineal hematoma, blood at the urethral meatus. No other abnormalities are noted. Examination of the pelvis shows no abnormality. Which of the following is the most appropriate next step in the management? Since
Ready?
ready?
Mm-hmm. So is retrograde urethropathy, a straddle injury resulting in a large perineal hematoma and blood at the urethral meatus, concern for urethral injury. Urethral injuries are characterized by difficulty voiding blood at the urethral meatus. Perineal ecchymosis and may be associated with a pelvic fracture. Straddle injuries can cause trauma to the anterior urethra, while pelvic fractures may injure the posterior urethra. Anterior urethral injuries are evaluated by retrograde urethropathy, which involves the injection of contrast into the urethra to evaluate for extravasation of contrast. Depending on the location and severity of the urethral injury, patients may be require surgical repair or the placement of a urethral catheter to help promote healing and prevent complications of urinary extravasation. Okay. Infection or retrocutaneous fistula or urethral stricture. Okay, next.
Okay. A 7-year-old Hispanic girl with a 1 year history of ALL is brought to the physician for a routine examination 6 weeks after starting treatment with two new chemotherapeutic medications. She has had decreased appetite, nausea, and increasing hair loss. Since starting treatment, she was in remission. Until 2 months, the child's parents state that there is an herbal remedy in Mexico that is believed to be a cure for daughter's condition with few side effects. They ask for physicians' help in obtaining the herbal remedy so they can discontinue their daughter's current medications. Which of the following is the most appropriate response to the patient's request?
Ready?
Yes.
Advise them to continue her medications while investigating the information further. When families inquire about naturopathic alternative treatments for patients being treated for life-threatening diseases, physicians should advise the family to continue the evidence-based treatment until the physician can further investigate the other treatment. Though patients and family autonomy are important factors in medical situation, adult patients with decisional capacity may opt to forego an evidence-based treatment in favor of a naturopathic treatment. Physicians should not withhold life-saving treatments from patients who lack decisional capacity, such as children. The physician should, however, research the help or remedy, discuss the risks and benefits of all treatment options with the family to address knowledge gaps, and collaboratively develop a treatment plan that aligns with their bodies. If the herb or remedy will not interact with the chemo regimen or harm the patient, the remedy may be incorporated into the treatment regimen. However, it should not take the place of medication with non-efficacy. If the family maintains that they want to discontinue the life-saving treatment and the physician believes that this will not be in the child's best interest, the physician may seek legal permission to proceed without the parental consent.
Okay, the next step, if patient does not want to continue the treatment, then we can contact with Child Protective Service.
Uh, mm, Not really. It says seek legal permission. So like go to
So,
court, like
oh,
yeah, kind of thing. Mhm.
okay. These things blows my mind. Okay.
Yeah.
A, a 6-year-old girl with nephrotic syndrome is brought to the physician because of 2-day history of fever, abdominal pain, swelling, loose stool. Fever, abdominal pain, swelling, loose stool. Her temperature is 39 degrees Celsius, 103 degrees Fahrenheit. Abdominal examination shows distension and diffuse tenderness and generalized rebound tenderness in all quadrants. Which of the following is the most likely diagnosis?
Constipation, enterocolitis, bacterial enterocolitis, fever. Okay.
Okay,
Okay. So spontaneous bacterial peritonitis, spontaneous SBP, is characterized by bacterial infection of ascitic fluid in the absence of an obvious source of infection, bowel perforation. Example, bowel perforation. Patients with underlying conditions that predispose to the formation of ascitic fluid, such as nephrotic symptom or cirrhosis, are at increased risk for spontaneous bacterial peritonitis. SBP may be caused by a variety of bacteria, commonly E. coli, Klebsiella. Patients present with fever, diffuse abdominal pain, nausea, vomiting, peritoneal signs like rebound tenderness. Leukocytosis diagnosis is confirmed with paracentesis demonstrating bacterial growth on cultures or the presence of more than 250 neutrophils. SBP may rapidly progress to sepsis. Treatment includes supportive care, NIV antibiotics. It's not necrotizing enterocolitis occurs in premature neonates and is characterized by necrosis of immature bowel. Does not commonly occur in toddlers or children. Okay, next.
okay. A 2-week-old girl is brought for her first well child examination. Newborn screening show increased TSH, increased thyroid hormone. Her mother takes propylthiouracil. Her mother takes propylthiouracil for hyperthyroidism. The patient is active, eating well. Examination show no abnormal. Which of the following is the Which of the following is the most appropriate management of this patient?
Ready?
Yes,
Mhm. So it's measurement of T4 and TSH concentrations. This patient with an increased TSH concentration at birth in the setting of maternal antithyroid medication use should receive a repeat measurement of T4 and TSH concentration. Increased TSH at birth can be caused by transient congenital hypothyroidism caused by placental transmission of maternal antithyroid medication or iron deficiency, or congenital primary hypothyroidism, commonly caused by embryological thyroid dysgenesis or defective thyroid hormone synthesis. Congenital hypothyroidism typically presents without symptoms as a result of placental crossing of maternal thyroid hormone. However, if hypothyroidism is left untreated, infants may develop lethargy, hypothermia, feeding problems, post chronic macroglycemia, hypotonia, umbilical jaundice, whatever, caused by impaired feeding and decreased bilirubin, dry skin, intellectual disability. Diagnostic testing shows increased TSH and decreased T4 at birth. The recovery of newborn thyroid function from maternal antithyroid medication typically takes up to like 2 weeks. So repeat serum testing should occur 2 weeks after birth in this patient. In patients with decreased thyroid hormone concentrations on serum testing,
I
thyroid
don't
scans.
understand the thing of the 2 weeks, the recovery. This is 2 weeks old girl.
Mhm,
Uh, so this recovery takes place within 2 weeks.
mhm.
So here, but his TSH is high.
No, they're not saying that the recovery, they're saying that you test again in 2 weeks. Since she's 2 weeks, that's why we're testing again.
Okay.
In patients with decreased thyroid hormone concentration on serum testing, thyroid scan and thyroid binding globulin concentrations help elucidate the cause of hypothyroidism. Distinguishing between thyroid dysgenesis and defective thyroid hormone synthesis. Management requires proactive newborn screening and levothyroxine. It's not a reassurance and follow-up exam in 1 month will be inappropriate because of increased TSH and unclear cause. Early detection and treatment of congenital hypothyroidism is crucial to prevent long-term disability. Not B, measurement of growth hormone concentration may be appropriate in patients with suspected central hypothyroidism who may present with symptoms concerning for deficiencies in TSH. Oh, okay. Along with other pituitary hormones such as growth hormone. These patients' lab instead demonstrate increased TSH, which indicates a dysfunctional thyroid gland and the cause of hypothyroidism. Measurement of serum thyroid binding globulin concentration of thyroid scan may ultimately be indicated to elucidate the cause of hypothyroidism. However, the physician must first perform repeat lab testing to confirm that the patient continues to demonstrate hypothyroidism. Thyroid binding globulin assists in the transport thyroid binding globulin of thyroid hormone to its target tissue, and decreased concentrations may indicate thyroid binding globulin deficiency or thyroid gland dysgenesis.
Next,
Mhm.
a female newborn is found to have mild cyanosis. A female newborn is found to have mild cyanosis periorally of the hands and the feet 4 hours after birth. She was born at 37 weeks of gestation following An uncomplicated pregnancy and spontaneous vaginal delivery Apgar's score was 9 out of 9 in 1 to 5 minutes respectively. She weighs 3.6 kg, temperature is 37 pulses, 160 per minute, respiration 60 per minute, blood pressure 90 by 40. The remainder of the examination shows no abnormality. Lab status shows hemoglobin 15 gram per deciliter, hematocrit 45%, leukocyte count 15,000, and platelet count 290,000. Which of the following is most likely diagnosis?
Mm. Mm. Between acrocyanosis and Addison's. Ready?
Yes,
Mm. With acrocyanosis, acrocyanosis refers to blue to purple color of the acral extremity, like hands and feet, and around the mouth. It is induced by peripheral vasoconstriction and is normal finding in healthy babies. Cyanosis is evaluated in the APGAR scoring performed at every hospital delivery at 1 in 5 minutes after birth. A neonate who's completely pink is given the maximum score of 2. A neonate with blue extremities is given a score of 1. And a neonate who's completely pale or blue is given a score of 0. The other components of the APGAR score, in addition to appearance, are pulse, grimace, activity, and respiration. Acrocyanosis is common in healthy newborn. Most healthy newborns do not achieve an APGAR score of 10 at either 1 to 5 minutes because of acrocyanosis, and in this case, it typically results within the first few days of life. Addison disease or chronic primary adrenal insufficiency present with diffuse hyperpigmentation of the skin and mucosa, not cyanosis. The patient does not demonstrate any signs of adrenal insufficiency, including hypotension or southwestern. Well, he is hypotensive, but okay. Next.
there is a frog in my throat. Okay, a 9-year-old boy 9-year-old boy is admitted in the hospital for treatment of status asthmaticus. He is intubated and the mechanically ventilated. His temperature is 37 Celsius pulse is 145 per minute, respiration 40 per minute, blood pressure 90 by 60. Examination showed decreased breath sound. Examination showed decreased breath sound over the right upper lobe. Chest X-ray shows tip of the endotracheal tube in the right tip in the right main stem bronchus and haziness of the right upper lobe. Which of the following most likely explanation of the X-ray finding?
Easiness.
Decreased breath sound.
Hmm. I don't know.
Breath sound is decreased in effusion, pleural effusion, decreasing, but in it also can happen in collapse also.
Ready?
Yes, collapse. Ready?
Mm-hmm. With alveolar collapse. Alveolar collapse, also known as atelectasis in the right upper lobe after intubation of the right main stem bronchus, is the most likely explanation for this patient chest X-ray finding. Right main stem bronchus intubation occurs more frequently than intubation of the left main stem bronchus because of anatomical disparities that preferentially direct the endotracheal tube toward the right when inserted too far. The takeoff of the right upper lobe, the takeoff of the right upper lobe bronchus is just distal to the origin of the right main stem bronchus. So an endotracheal tube that is inserted beyond the right upper lobe takeoff can obstruct this bronchus. Wait. The takeoff of the right upper lobe bronchus is just distal to the origin of the right mainstem bronchus. Okay. So the trachea tube that is inserted beyond the right upper lobe takeoff can obstruct this right bronchus. Okay. Obstruction means that no air can enter or exit the bronchus, which results in air trapping within the respective alveoli. Air is gradually resolved, leading to complete alveolar collapse, absorption atelectasis. This appears on the chest X-ray as haziness in the affected lobe. Management requires subtracting the endotracheal tube to the correct position, which is typically like 2 to 6 centimeters above the carina. Atelectasis will gradually resolve with improved ventilation and positive pressure within the affected lobe. Air trapping occurs initially after obstruction of the bronchus, but air is gradually reabsorbed in the affected lobe, leading to complete collapse of the alveoli. Collapsed lung is denser and therefore radio-opaque, which is what gives it a characteristic hazy appearance on chest X-ray. Okay.
Next, a 3-year-old girl is brought. Sorry,
Did not say anything.
a 3-year-old girl is brought to the physician by her mother, who is concerned that her daughter might have been abused. The mother states that her daughter have been touching her genital areas since she began attending daycare 6 weeks ago. The mother says, I have heard bad things happening to the kids in a daycare. The patient is a cricketer and is occasionally deafened. She has had intermittent nighttime awakening. She interacts well with other children but sometimes does not want to share her toys. She separates from her mother after initial hesitation when dropped off the preschool. Her teachers reports no behavioral problem today. The patient appears mildly anxious. Uh, Physical examination show no abnormal. Which of the following is the most appropriate next step?
Ready?
Yes.
So it's reassure the mother that this is normal behavior. Um, this patient's social development is normative. Starting at age 2, toddlers become more curious about the genitals and associated sensations, along with gender difference. Normative sexual behavior of toddlers includes solitary behavior such as touching their own genitals, along with social behavior such as looking at another person's genitals. Sexual behaviors that are concerning for sexual abuse or violence or neglect in the home include limitations of specific sexual acts, coercive sexual behavior, and excessive preoccupation with sexual behavior. Toddlers demonstrate occasional defiance and cooperative play is not expected to develop until like 4 years old. So this child in his inclination not to share her toys is typical. Nighttime awakening, picky eating, and anxiety about physician appointments are also typical for toddler. Sexual abuse may lead to sexual behavior problems. Physicians are mandated to investigate and report suspected abuse to Child Protective Services. Problem behaviors include imitating sexual acts along with coercive sexual behavior and excessive preoccupation with sexual behavior. Okay, we are done.
Okay, we are done.
You want to take a break before we start
Okay.
the next? Okay.
A pediatric 7, isn't it?
Yes.
Okay.